All right, hello and welcome everyone to our latest event in the precision medicine and oncology event space. We're glad you joined us for this talk. Today, our speaker is Dr. Rachel Mariani from Phoenix Children's Hospital, who will be discussing the medical laboratory scientist, the first step of blood cancer personalized medicine. Here's a quick look at today's agenda. My name is Ian, and I'm a network development manager with Diaceutics. I'll provide a short background about Diaceutics as a whole, as well as DXRX, our precision medicine platform for labs. I'll then turn it over to Dr. Mariani for her presentation. And at the end of the presentation, we'll dedicate some time for questions and answers, where we'll be able to answer any questions you have. Please note, you can ask questions at any time during the talk by typing them in the box below this presentation. Diaceutics is an end-to-end services provider and data analytics company specializing in precision medicine. Our mission is better testing, better treatment, and we're building towards a future where the testing ecosystem allows all patients to receive the right treatments at the right time. We believe that labs need to be involved earlier in the precision medicine decision-making process. We have experience in 96 disease pathways and have worked with 36 of the top 40 pharma clients. And we have a global presence across 53 countries, which enables knowledge sharing across a vast range of topics. All diagnostic labs can find a benefit from a DXRX registration, regardless of shape or size, and we see this collaboration having a positive patient impact all over the globe. Our goal is to break down global barriers between labs, and we see DXRX as the way to accomplish this. With a free DXRX membership, you receive access to easy to navigate US claims dashboards, a curated feed of CDX and precision medicine news and resources, visibility to Diaceutics and pharma-sponsored collaborations for both labs and pathologists, as well as additional lab-focused webinars from pathologist speakers like the one you are tuned into right now. On both the left side of the screen and in the DXRX booth in the exhibit hall, you'll find a link where you can schedule a meeting with a network development manager to learn more about DXRX and joining our lab network. We'd love to meet with you. It is now my pleasure to introduce Dr. Rachel Mariani. Dr. Mariani is a hematopathologist serving patients in Phoenix, Arizona. Her clinical and research interests include identifying various biomarkers for disease prognostication and developing streamlined lab testing algorithms in modern practice. Dr. Mariani is the hematopathology section director and medical director of the flow cytometry lab in the Division of Pathology and Lab Medicine at Phoenix Children's Hospital. Thank you for joining us today, Dr. Mariani. We're excited to hear from you. And with that, the floor is yours.
Okay, thank you, Ian, and thank you everyone who's here live, and thank you to those who may be listening to the recorded version. And I just wanted to reiterate one of the goals that Ian had mentioned with Diaceutics, and that's getting the labs and pathology involved earlier. And really to those MLSs and other lab folk in the audience, you guys already know that you are really the first line when it comes to labs and providing the best information and diagnosis that we can for our patients and other physicians. So this was really a topic that spoke to me, and I'm so glad to be able to be here and discuss this with you. So according to the United States Center for Disease Control, up to 70% of today's medical decisions depend on lab test results, and nearly 14 billion lab tests are ordered annually. And it's probably no surprise to those in the audience that globally in healthcare systems, lab scientists are the first step in diagnosis and treatment of many disorders. And so in honor of the topic is on blood cancer, I wanted to go into understanding what is blood cancer. So it quite literally is a malignant proliferation of any cell line in the blood. And as I'm sure everyone on this call knows, that the blood consists of white blood cells, red blood cells, and platelets. So blood cancer really is a malignant disorder in any of these cell lines. When we say blood cancer, we tend to think first of cancers in the white blood cells. And this talk will talk about and focus on those entities. But I did want to highlight just some other areas that we may not see, some other disease entities. So polycythemia vera is a malignant disorder of red blood cells. And essential thrombocythemia is a malignant disorder that results in platelet proliferation or thrombocythemia. So going back to the malignant disorders and proliferations of white blood cells, we can kind of broadly think about these in different categories, and it's based on where in the cell maturation process the proliferation process arises. So for instance, in the most immature cells, in these blood stem cells, and even when they further differentiate into their myeloid or lymphoid components, those are acute leukemias. We also can have chronic leukemias and other disorders, and those tend to arise in the more mature forms of myeloid cells, like the monocytes or the granulocytes. Lymphomas are malignant proliferations of mature lymphocytes that includes B, T, and natural killer cells. And then myeloma, it could be considered a lymphoma based on its maturation, but it really is a separate entity. Myeloma is a malignant proliferation of plasma cells, and plasma cells are the final differentiation step of B lymphocytes. So as I was preparing for this presentation and just thinking more about Blood Cancer Awareness Month, which is September, I was wondering, how did this all come to be? So in the 1970s is when leukemia was really put in the spotlight, and more attention was put onto of research and diagnostic concern. And then as time went on, lymphoma joined the picture in the early 2000s. And as we saw, blood cancer is all of these areas. Myeloma then joined later on. And then coming into 2010, which was really the first year that blood cancer had its own time in the spotlight, in September, other hematologic malignancies were included as well. So with all of that, let's focus on our objectives for today's talk. So I want to identify key clinical and morphologic features of various myeloid and lymphoid malignancies. I thought about entities that would be more frequently encountered in many lab settings, and I wanted to make sure I covered all age range or all range of the age spectrum. So we will be looking at pediatric as well as adult patients in today's discussion. I also recognize essential biomarkers for diagnosis and prognostication. And remember, biomarkers are not just genes or chromosome abnormalities. Biomarkers can also include an immunophenotype. So say what the flow cytometry shows. And then what is really important for all of us is to think about designing an effective strategy for specimen utilization based on the needs of the lab setting and the patient population we serve. And in our lab, we have these things called hematology bench aids. And this is a common term. I'm sure everyone is also familiar with this. These can come in the form of published textbooks, or they can even be tailor-made sheets or papers that each lab keeps in their certain area of the bench. And I wanted to summarize important aspects of each case in these hematology bench aids. So these will be at the end of the first three cases. The fourth case is a little bit unique. It presents findings from a bone marrow aspirate. And not all MLSs, not all hematology labs will have the chance to look at bone marrows. So I understand that this can be a pretty specialized area of practice, but I did want to take this opportunity to show you an interesting case that involves the bone marrow mostly. So let's move to our first case. And also, I want to point out that under the first or at the beginning of the slide for each case, I'm trying to indicate the lab setting. So for instance, this is a case that was sent to an independent or reference lab. So it's not on the grounds within a hospital or within a healthcare system, because these are the different areas and environments. So the patient is a 12-year-old male, and the information that is received in the hematology are the lab orders. So the provider ordered a CBC with a differential count. And the specimen that was received is peripheral blood that was drawn in EDTA, about 2.5 milliliters. So the automatic differential was flagged for manual review. And you can see there are a lot of abnormal values here, and those are in red. The patient has anemia, and it's normal, or it's normocytic. The MCV is normal. Platelet count is normal, but you can see there is a leukocytosis. The white blood cell count is elevated, and essentially every cell line except for the lymphocytes is increased. And most notably, there is an absolute eosinophilia and an absolute basophilia, and there are some blasts present. So here's a low power view of the peripheral smear, and you can see there are a lot of white blood cells. There's leukocytosis. And then looking more closely, what are these cells? So these arrows are indicating basophils. In another field, we can see an eosinophil next to some other immature granulocytes. And then at the right hand of the cell cluster, we see a more immature cell. This looks blastic. Let's just leave it at that. It looks like a blast. And then in another field, we can see some other immature cells as well, blasts. And I'm intentionally not trying to identify their lineage just yet, but these are blasts. And remember, there were immature granulocytes and blasts in the smear. So based on these findings, the alert values were called to the physician's office. And at that point, some clinical history was provided to the person who was calling from the lab side. And we learned that the child that had presented to clinic for a back to school or a sports physical examination. And the mother had noted that the child seemed to have more bruising and fatigue, but both the patient and their mom attributed it to restarting athletic practices. And on physical exam, the pertinent positives included, there were bruises on the shoulder and the back, but pertinent negative included there was no palpable hepatosplenomegaly. So when the doctor did a physical exam on the abdomen, there were no lumps and bumps that could be felt. The organs felt, based on the physical exam, to be a normal size. And interestingly, the family had left for a 1-week cruise boat vacation. So they had already gone to the airport. They were already off to the Bahamas, where they were vacationing on the cruise. So I like to put in some polls and provide for some interactive opportunities. So based on this presentation, based on what we've seen from the lab values, what is probably the next best test to obtain in this case? So would it be flow cytometry, or cytogenetic and FISH studies, or molecular sequencing? Okay, somebody weighed in and said cytogenetic FISH studies. I completely agree. And there's not a right or wrong answer. Again, it's the next best test. And so, with the limited amount of specimen that was available, with the disposition of the patient being on vacation, probably best to use cytogenetic fish studies. And luckily at this reference lab and with the testing algorithm and communication with the provider, they were able to say we should do fish and further examine what is going on in this blood. So this is a case of chronic myeloid leukemia. And CML is a myeloproliferative neoplasm that's characterized by granulocytosis. So we saw that in the peripheral blood. We saw a lot of granulocytes, right? Eosinophils, basophils, and neutrophils. And we saw them in various maturation states. And CML, I think in general, we tend to think of this as a disease occurring mostly in older adults, but it can occur in all ages. Yes, it is more frequent in patients greater than 55 years old, but this can afflict children as well. So the World Health Organization provides classification and information for diagnosis and prognostication for pathologists and MLS individuals. And the World Health Organization had previously described CML having three phases: a chronic phase, an accelerated phase, and then a blast crisis. But the WHO has recently updated their classification and their description of diseases. And in the most recent update, accelerated phase designation is not as useful as it used to be. And that's due to the impact of using tyrosine kinase inhibitor therapy. So along with the WHO, some in the audience may have heard of the International Consensus Classification, the ICC. This is a newly proposed classification system for hematopoietic malignancies. And they have a similar approach to the previous WHO classification, including an accelerated and a blast phase. But I want to focus on the top, the WHO, and just introduce what those more recent features are and classification of CML based on the findings in the peripheral blood, as well as chromosomal abnormalities. So instead of accelerated phase, we now want to look at features that are associated with high risk, and these present in the chronic phase. And most patients tend to present in the chronic phase. This patient example is presenting in the chronic phase. And he had fewer than 10% blasts in the peripheral blood. Other than the basophils and the eosinophils being considered, in the high risk phase, if you have 20% basophils in the peripheral blood, that is a positive finding for high risk. Additional chromosomal abnormalities in the Philadelphia chromosome cells, and this is included here. These, along with the higher blast count, are features of high risk for patients that are presenting in the chronic phase. So how do we distinguish between chronic phase and blast phase? Well, it's pretty much have not. So patients that are in the high risk chronic phase do not have 20% or more myeloid blasts in the peripheral blood or bone marrow. They do not have extramedullary blast proliferation, and you do not detect lymphoblasts. So these are features of the blast phase, as you can see in the orange box. Okay, so I'm going to go back to why I was a bit elusive on specifying what kind of blasts were present in the peripheral blood. It's important to distinguish which blasts are in the peripheral blood because, again, remember, the bone marrow is kicking out all of these immature cells. So even though when we tend to see blasts, we tend to start thinking along the lines of myeloid versus lymphoid, but the bone marrow can kick out the immature erythroid blasts as well. So on the top bar, you can see this is actually a blast of the erythroid series. Versus on the bottom, this is another image of a cell in the patient's blood. This is a blast of the granulocytic series, and it can be difficult sometimes to distinguish these blasts. Myeloid blasts, as many in the audience know from experience, can present in a variety of morphologies, and they can be tricky. And in CML, we also don't have features that are associated with other malignancies like our rods. So we could say that sometimes flow can be of utility. So I did see that some people responded, yes, we should do flow in the poll. And that's not a wrong answer. But we tend to try to use our morphology to then decide what would be the next testing, kind of a triage. And in our era of limited specimen availability and limited specimen collection, we want to be cognizant of what would be the next best test. So chronic myeloid leukemia is defined by a BCR ABL1 fusion, and this is resulting in the Philadelphia chromosome. The Philadelphia chromosome produces a protein that's a tyrosine kinase signaling protein, and it causes cell proliferation. And then based on the breakpoint of the BCR gene, there can be different BCR ABL1 protein isoforms, and these can actually be used for disease monitoring. So this is where our molecular tests are quite helpful to help us identify, is this a P190, is this a P210, or P230 isoforms? These are the most common. And there are many labs that can run RT-PCR and look for these at various stages of presentation and monitoring. So summarizing this case with the bench aid for CML, it can affect all ages. It is more common in those patients greater than 55 years old. But remember, kids can present with this too. Eosinophilia and or basophilia is common. It's important to get an accurate basophil count because remember, this can help identify this as a high-risk feature in a chronic disease presentation. It provides prognostic information. And then an accurate blast count is important as well, and making sure that we identify as best as we can with whatever modalities are available, whether that's just morphologic review or if there is accompanying flow cytometry analysis. We want to identify that blast lineage because that can provide, again, prognostic information distinguishing between the high risk or accelerated phase and the blast phase. And it can inform therapy. And then in the chronic phase, which what this patient presented in, flow is generally of little utility. And we want to try to prioritize cytogenetic FISH studies at initial diagnosis, and then sequence for the isoforms to follow any residual disease. So moving to our next case, this is also a case presenting to an independent or reference laboratory, and it's a 66-year-old male. And the hematology lab orders came with a nice written note from the provider saying they suspected lymphoma based on a skin rash and the presence of lymphadenopathy. So they were ordering a CBC with differential count and a manual review. They were also ordering flow. They provided 3.5 milliliters of blood collected in EDTA. So the automated differential showed the findings below, and a manual review was performed per the flags and also per the order that was placed. So there was no anemia, the patient's hemoglobin was normal, and the platelet count was normal. They did have a leukocytosis that consisted of lymphocytes. So there was absolute lymphocytosis. So looking at the smear, there are increased numbers of lymphocytes. And when we look at them at higher power, we can see that they have a little bit of a funny nuclear configuration. Some of them seem to have very prominent folds, and kind of impart this cerebriform appearance, kind of folded up. Cerebriform means like a brain. And looking at the flow cytometry, there was an abnormal mature T cell population present. And these T cells comprised approximately 45% of the total CD3 positive events, and they were positive for CD4, for TCR alpha beta, and they were negative for CD7. So based on the morphologic appearance of these cells, and also the other contextual clues from the clinical information and the flow, we can safely say that these represent Sézary cells. And Sézary cells are mature T cells. They're positive for CD3, CD4, and the T cell receptor alpha beta. They frequently lose other T cell antigens like 2, 5, and 7. And they are intermediate to large atypical lymphocytes, and they have this cerebriform nucleus. It's abnormally shaped. It shows grooves. It's best to think of it, it looks like little brains. That's why we use cerebriform. And with the information, once these findings were given back to the physician who ordered this test, the patient was diagnosed with Sézary syndrome. So Sézary syndrome is a mature T cell lymphoma, and it most frequently presents in the blood. It is more predominant in males, and it tends to afflict patients greater than 50 years old. And there is a triad of findings required for the diagnosis. So the diagnostic criteria involve skin findings, erythroderma involving more than 80% of the body surface area. There is also evidence of blood involvement by a neoplastic T cell population defined by clonal T cell receptor gene rearrangements. And then where the findings that I presented in the smear and the flow come in, there are 3 findings that can be used for completing this triad. We could have an absolute Sézary cell count of greater than 1,000, or there is an expanded CD4 positive T cell population with an aberrant ratio of CD4 to CD8 greater than 10, or there's an expanded CD4 positive T cell population with an abnormal phenotype, and that's listed below. And this case shows the abnormal phenotype above with the CD4 positive and the loss of CD7. Now, the immunophenotype and the morphologic findings are not specific for Sézary syndrome. And that's why it's important that the ordering provider take all of this into consideration, and why I want to emphasize that from our perspective in the lab, we can't always definitively say that, yes, this is Sézary, or yes, this is this particular T cell lymphoma. So our next slide will explain that a little bit more. And this is a busy slide. You don't need to look at every box here, but I did want to kind of overwhelm you with this slide to show that there is a lot to take into consideration when making a diagnosis of a T cell lymphoma, especially when we only have maybe a peripheral blood smear and flow. So flow cytometry diagnosis of T cell lymphomas requires most often incorporation of other findings, which we may or may not be aware of: the clinical presentation, imaging findings, and then cellular morphology, which oftentimes we can provide finding or the results of, right? And then molecular studies in some instances. A small number of entities do have a specific diagnostic immunophenotype. So in many lab settings, it's wise to include a differential diagnosis, again, when appropriate, when clinical information is unavailable, as can be the setting in an independent or reference lab. So I want to also, in this case vignette, show a different patient. I want to show this 3-year-old that had fever, and they did have a mild absolute lymphocytosis. And we can see that there are some lymphocytes here that have nuclear features that are suggestive of a cerebriform appearance. In fact, I would say that there are some tiny little brains in this picture. They look pretty Caesary. Here's another field. And then the cell on the top is a large granular lymphocyte. We can see the granules in the cytoplasm. So Caesary morphology, it's not specific to Sézary syndrome. Small and intermediate Sézary-like cells can be seen in benign conditions, and they can be seen in conditions such as dermatitis, psoriasis, eczema, drug reactions, and importantly, they can be an incidental finding in otherwise healthy elderly patients or children. So the presence of large Sézary cells is suggestive, but it's not specific. So here on the right side, I'm showing some examples of Sézary cells in confirmed Sézary syndrome in a patient different than the one that I showed. But you can see that this finding alone is insufficient to say this is Sézary syndrome or that these even represent neoplastic cells. Again, we have to incorporate the other findings when they're available to us. So going back to this patient, the patient presented to our oncology clinic after their primary care reviewed the comment from the CBC and smear review that was performed at a separate independent laboratory. The comment read that there was absolute lymphocytosis consisting of mature, well-differentiated forms. These findings were suggestive of a lymphoproliferative process such as chronic lymphocytic leukemia, CLL, or the peripheral phase of a lymphoma. So this comment was a little bit problematic for a few reasons. One of the main reasons is CLL, chronic lymphocytic leukemia, it does not arise in children. We never say never, right? Medicine is never 100%, but CLL is not a disease of children. So I include this not to criticize, but to highlight that, again, when we're in a different setting, when we are not necessarily in a setting that's associated with a hospital or a clinic, and the patient chart and clinical information is not readily available to us, it can be challenging to provide a diagnosis and interpretation of the findings. But one thing we can try to use is information based on the patient's age. So when it's possible, we want to try to create and use canned responses and comments in the context of the patient age, and then if we have any other associated findings. So for this case, the points that I really wanted to emphasize in the hematology bench aid are to interpret the cell morphology in the context of the clinical and/or additional lab information when possible. Some lymphomas have a specific diagnostic immunophenotype. Others require additional correlation with morphology, imaging studies, and other clinical findings. We should try to use canned responses in an age-appropriate manner when possible. And then T-cell lymphomas, even though I didn't really emphasize this in the vignette, T-cell lymphomas are generally more prevalent in adults than in children. They can afflict children, but that is one thing to keep in mind. Okay, so I would like to pause and allow the audience an opportunity to weigh in and ask any questions about these first two cases.
Yeah, thank you, Dr. Mariani. So if anyone has any questions, there is a bar at the bottom of your screen that you can type them in. Feel free to ask them now. We'll stay on for a few seconds, see if anything comes through. Additionally, though, we will have another Q&A session at the end. So if there's any questions, for the second half of the presentation or still part of this first half, feel free to ask them at any time as well. So with that, I'll stay on for a few seconds, see if anything comes through, and then we'll go from there. All right, looks like we're still waiting on some stuff to come through. People still formulating their thoughts. So Dr. Mariani, I'll drop off and I will let you continue. And I'll see you at the end.
No problem. Thank you. Okay, so let's move on to our third case. And the lab setting is in a hospital lab. So we're on site at the institution. We have access to the electronic medical record and should be easier to communicate with the clinical team taking care of the patient. So this is a 16-year-old female. And the lab orders received in the hematology lab are a CBC with differential count, and then also a PT, a PTT, and fibrinogen were ordered from the coagulation bench. Specimen received was peripheral blood collected in EDTA, and then peripheral blood collected in sodium citrate for those coag tests. So the clinical history for this teenager is that she presented to her pediatrician the day prior for evaluation of worsening fatigue, and she also noticed that her gums were bleeding. So her pediatrician ordered a CBC, and that showed an elevated white blood cell count. And she reached out to the patient and her parents and instructed her to go to the emergency department due to concerning findings and elevated counts on that CBC. And so a repeat CBC and accompanying coagulation studies were then ordered in the ED. So the CBC showed that there was leukocytosis, the white blood cell count was increased. This patient had anemia that was microcytic, and she also had thrombocytopenia. Her platelets were 30. Now, on the differential, there was absolute neutropenia, and there were some myelocytes in the peripheral blood, but most concerning, there were blasts. So let's look at what her blood smear showed. So here we can see some atypical immature cells. And at low power, we can already see that they have a unique nuclear appearance. They have folded nuclei. Some have a bit of a plate on plate or a butterfly or even a figure 8 configuration. And they have a relatively abundant amount of cytoplasm. And here's another image showing the variety of the morphologic appearance of these cellular nuclei. And in one of these forms, we can see fine granules, but notably, we could not see our rods, and these cells did not have a really prominent granulocytic or appearance of granules in their cytoplasm. So after reviewing the smear, the coagulation studies were finalized, and this patient had prolonged PT, and her fibrinogen levels were low. So there is a coagulopathy. There was also an order for flow cytometry. And in the lab, the algorithm was such that our MLSs were able to say, this specimen needs flow cytometry. So I was alerted about this patient after they said, hey, we see blasts and we've already fired up the flow cytometer and have started staining the specimen, and we're going to be running flow. So here are the dot plots for the flow run on this peripheral blood. And we can see that there is an accumulation of events in the moderate CD45 and moderate side scatter area. And this is encompassing kind of the bottom end of where mature granulocytes will be regarding their side scatter. And it's also going into the monocytic area. But clearly, there is a large population of events converging at this area. We saw that these events were pretty bright for CD33, and they did show some heterogeneity of HLA-DR. There was partial CD34 expression, and there was very dim CD117. They are positive for CD13, and they're negative for CD11C. So this was a little bit tricky of a case, but based on the findings that we have so far, would you say that these findings are most suggestive of acute lymphoblastic leukemia, acute promyelocytic leukemia, or acute myeloid leukemia not otherwise specified? And we'll allow some seconds for people to weigh in and think about this case. Okay, so I got some takers for acute myeloid leukemia not otherwise specified. And technically at this point, we don't have any molecular or cytogenetic findings. So we can say that we have acute myeloid leukemia not otherwise specified. So let's investigate what more we should do with this case. So actually, I'm going to go back. I'm going to show the morphology just again. So this is a tricky case. This patient is a teenager. She has coagulopathy. There's prolongation of the PT, and her fibrinogen is low. I'm just pausing to allow for my network connections. Apologies. And let's look at the morphology again. There are folded nuclei. There is kind of this butterfly or almost figure 8 form here. And there are no hour rods. And then we're looking at the peripheral blood flow here. And it does show this pattern that is suggestive of a myeloid lineage. So this is actually acute promyelocytic leukemia, and it is the hypogranular form. So we want to send this for fast fish. And this is my only funny slide, just because I was curious during the presentation when I was making this presentation. I wonder what fast fish are. So here, if anybody was curious about who the fastest fish are, here are the fastest fish. But that's not what we're looking at. We are looking at fast fish that requires 1 hour hybridization. And we want to do this on our cases that we suspect for APL, because we can get the results within 2 to 4 hours. So in this case, a PML rara fusion was detected, and that is diagnostic of APL. So this LinkedIn post by Laboratory, and I encourage you to check it out, really describes nice description of the morphology of the cells. And we used to use the term hypogranular. Microgranular is kind of what is more encouraged, but hypogranular, microgranular, as long as we identify these cells, that's the main takeaway. And these cells can have a nice figure 8 morphology, or they can have a morphology that's been described as a butterfly, or it's also been described as stacking a plate on a plate. Whatever works for you, just try to keep in mind that these are morphologic examples and we want to keep our eyes peeled for them. And that's because these patients can have derangements of their coagulation cascade and ability. Now, coagulation abnormalities are not specific to APL, but they tend to go along with APL cases. We actually just had a patient present last week with an AML that was not APL, and they did have abnormal coagulation. But these morphologic findings, along with the flow cytometry, can be suggestive. So there are two flavors of APL that we see most frequently. We see the APL hypergranular, which is kind of that more traditional where we have the hour rods and the very heavily granulocytic cytoplasm. And then we have the case that we saw for the APL microgranular. And in the red boxes, I've highlighted kind of some of the differences between the two immunophenotypes. And we see this in our case example. The side scatter can be decreased in the APL, and we do see that in our APL microgranular. We have bright CD13 in our case, and then we also have positivity for CD34. So along with the morphologic, the flow findings, and then the confirmation by the fast fish, we had APL, the microgranular form. So here are some examples of our rods and cytoplasmic granules, and then a higher power of that nuclear configuration. And this, I think, is very nicely showing that plate-on-plate stacked configuration. So APL is part of a relatively new or expanded group of leukemias that do not require 20% or more blasts for a diagnosis of leukemia. So that means even if we detected only 10% blasts, and this patient actually did have fewer than 20% blasts in the peripheral blood, this is still leukemia. So there is an expanded list, as I said, of acute myeloid leukemias that are diagnosed by their defined genetic abnormalities. So that includes APL, and that includes all of these leukemias except those that I have marked off. That's an AML with BCR-ABL1 fusion and an AML with SEBPA mutation. So the hematology bench aid highlighting the important takeaway features for APL is that any suspected case of APL should be worked up and identified immediately, worked up to the max. And whatever that means for the specimen that's available, whatever that means for the testing that's available in your lab, and or the ability to get in touch with the ordering provider. Coagulopathy is common, and it's important to identify because there's a risk of disseminated intravascular coagulation, DIC. APL can affect all ages. APL is one of the subtypes of leukemia that does not require 20% blasts for diagnosis. And it's important for us in the lab to be familiar with the morphology and the immunophenotype, if you have flow available, of hypergranular and microgranular forms. Okay, so case 4, as I mentioned in the beginning, this is kind of our bonus case, and I'm not going to include a hematology bench aid. This, again, is going to be a presentation of bone marrow findings, and we don't all get to see bone marrow in our practices, right? Not all MLSs will be looking at bone marrows. But I wanted to show this as an example of some interesting morphology and also to be inclusive of all of those entities that we discussed as being part of our blood cancers in this Blood Cancer Awareness Month. So this is occurring in the setting of a hospital lab, and it's a 71-year-old male. And in the hematology, there was a bone marrow aspirate received, and the slide is reviewed. And we received bone marrow collected in EDTA and sodium heparin. So this patient had presented to the ED for evaluation of back pain, and CT was obtained that showed multiple lytic lesions in the vertebrae. So the patient was admitted for further workup, and that included a CBC with differential, a complete metabolic panel, CMP, serum immunofixation electrophoresis, and a bone marrow biopsy. So the results of those studies showed the patient had anemia and he was thrombocytopenic. There were no abnormalities with the white blood cell differential. Everything was within normal limits. His complete metabolic panel, I'm showing just some relevant findings from it. This is not the complete metabolic panel, showed that his calcium was elevated. And the serum immunofixation showed that there was an IgG, and the light chain showed that it was a lambda. So in, in the bone marrow aspirate, we see that there is a predominance of erythroid precursors. Those are the cells, I did not highlight them with an arrow. They're smaller, they have very, very round nuclei, and their cytoplasm is kind of gray. But spread out amongst those, interspersed, are these larger cells that are highlighted by arrows. They have a relatively abundant amount of cytoplasm that is blue. And then they have this lighter area adjacent to the nucleus. We call it a HOF, a perinuclear HOF, and it's a cleared area. And then there are some forms that have multiple nuclei. There's a mononuclear form, and then there's also a trinuclear form. In other areas of the smear, we saw these types of cells that are indicated by the arrows. And they have, again, similar findings. A relatively abundant amount of cytoplasm, that clearing next to the nucleus. Their nucleus is pretty round. And we can also see that there are kind of these projections almost on their cytoplasm that look pink in these certain areas. Here's another field, and then on the right, I've shown those cells at higher power. So flow cytometry in a conjunction with the morphologic findings showed that there was a plasma cell population that was abnormal, and it was lambda light chain restricted, and it had an aberrant immunophenotype. We were able to identify plasma cells by their bright CD38 expression. They were almost completely negative for CD19, and they showed CD56. They had partial CD20 expression, and they also did show CD138. So CD38 and 138 were good for drawing out those plasma cells. And then we can see that they were, these axes are labeled wrong because this was a lambda restricted population. So where it says kappa on the y-axis, this should be lambda. But the final diagnosis with the lab findings, with the morphologic findings, and then his clinical imaging findings is multiple myeloma. So multiple myeloma is a diagnosis that requires integration of many findings from the clinical presentation, lab imaging, and other findings. So it's essential that there is a clonal population of plasma cells or a bony or extramedullary plasmacytoma. So this patient had a clonal bone marrow plasma cell population. And then he also had myeloma defining events. And I won't read through this list just for the sake of time. But this was, again, just the case that I wanted to show the morphologic findings because we don't always get to see bone marrow aspirate, and also to highlight that diagnosis of entities does require integration of all these clinical findings, some of which are not always readily available to us in the lab. So remember, blood cancers are from white blood cells, red blood cells, and platelets, but we tend to focus more on those white cell disorders. And here's a nice picture showing those separate areas and the entities that we've touched on. So with that, I will end and allow for the audience to ask any question, and I thank you for your attention.
Yeah, thank you, Dr. Mariani, for that awesome talk, for joining us for Blood Cancer Awareness Month and highlighting the important roles that our MLSs and other lab professionals play in this. So we'll go through. We got a couple questions in so far, and like I told everyone before, feel free to type them in during this session as well. But the first question we have is, there are leukemias that are called chronic or acute. Can you explain why leukemia is used and how to tell the difference between those cases?
Yes. So we tend to use leukemia as a designation when the disease presents in a disseminated form in the peripheral blood. And it can get confusing because the treatments are definitely different for what type of leukemia it is. So the designation for acute and chronic then depends on at what stage of maturation the disease cell is. So when it's a stem cell or when it's before that mature form, this is called acute. And acute can also be tricky too, because we can say that acute is something urgent. These are all urgent, but that's what acute means in this context. Now, chronic is indicating that the cell is mature. It's either at its most mature form, or it's already at a stage of maturation. So for instance, I did not talk about chronic lymphocytic leukemia. I briefly mentioned it when I was discussing the case of the Sézary, the T-cell lymphoma. But chronic lymphocytic leukemia is a disorder of mature B cells, and it presents most frequently in the blood. Sometimes there can be lymphadenopathy and splenomegaly, but this is a mostly blood presentation. So again, leukemia is used when the disease is presenting mostly in that disseminated peripheral blood involvement form.
Thank you for that. Our next question is, you mentioned two classification systems. Where are those published?
Yes. So there is the WHO, and we also call this the Blue Book. And the WHO is published in tomes, they're published in books. It's also available at their website electronically. Now, the ICC is a more recent classification, and these classification paradigms have been published in different manuscripts, and they are available in Virchow's archive. So hopefully your institution has a subscription or access to PubMed, and those are available. From the MLS perspective, we don't often have to get too concerned about understanding what all of the nuances are for those, but it's good to be aware that these classification systems exist. And the ICC, the International Classification Consensus, will be, or consensus classification will be, I think, published in a textbook that is forthcoming, but there's to be more information about that in the future.
Thank you. And we got time for one more question. Do you feel like it is important for MLSs to stay informed on precision medicine updates, such as new therapies, and does this impact their daily work?
I do think it is important to be aware. Again, I think that the nuances we don't need to be too concerned about the nuances, but we do need to be aware of what is in the pipeline and what is available, because that informs some of our testing. That informs areas, even like in flow cytometry. Are we looking for a certain CD marker? Because now we have a targeted therapy against that CD marker, that biomarker in a particular disease. I think it's always important for MLSs to seek out information, but I think it's also my role as the hematology lab director to be sharing that information and making us available as a team. So I do think it's a team effort. And when I say we don't need to be concerned with nuances, I mean not to stress about it, to be informed, but to not let it be a stressful thing. Don't let it overwhelm you. I always encourage everyone to dive into the literature, to seek out opportunities such as these to learn more, and even to reach out to companies and just ask more about what their therapies are and how you can understand your role in helping the patient achieve that therapy treatment.
Yeah, thank you. That's fantastic advice and fantastic outlook. So with that, we've come to a close on this presentation. So a big thank you again to Dr. Mariani, and big thank you to everyone in the audience as well. We'd love to speak with you and connect with you about DXRX. So please check out the link if you'd like to book a meeting. And we encourage everyone to stay connected with Diaceutics for future events like this one. Thank you again to everyone, and we hope everyone enjoys the rest of their day.